One of the questions obviously is, with what toxicity will they come? So maybe you want to address, first of all, because you published that data on the bone mineral density loss, are we really going to worry about that? If TAF is now becoming available, isn't that going to replace tenofovir? What would be your ideas around that? And then thinking of the immune-based therapies, and I think you made a very strong effort in sort of redefining our classification of disease, and that probably the immune system is sort of doing something all the time, and there's really not that much difference between the sort of artificial separation we're doing, and that means that probably we have to target everyone. But don't some of these immunological interventions come with quite some toxicity, like PD-1 inhibition could induce autoimmune disease, and is that in a balance to a viral disease where we can actually control replication?
That's very good questions and very good points. I'll start with the first one first. Every one of us who treats our patients in the clinic worry about the side effect of these drugs. And, for a long time we thought tenofovir was a fantastic drug, viral suppression, high barrier to resistance. But yes, there's been hints over the years, and I think it's clear that there is some toxicity. And of course, yes, if there's a drug with less toxicity, such as TAF, I would be a huge advocate for using these drugs. And if you know from my talks and from our work that I'm a real advocate possibly in treating patients earlier, because I think if we treat patients earlier, we may have a better outcome. If you're going to treat patients earlier, the one thing you need to know is that the drugs are at another level in terms of reducing the level of toxicity. And that's why I would be an advocate of using cleaner drugs like TAF. So I certainly think there's a place for that. I'm not so sure what the payers in the UK and Europe and across globally will think about that, but that's something that I think we'll need to consider more as we move forward. The next point is a very important point. We talk in general terms about PD-1 blockade. First of all, we have to kind of disentangle the various aspects of this. PD-1 blockade in a patient with a progressive cancer is a very different strategy to employ in the clinic from somebody who's attending your clinic, taking a medication which may not be causing them all that amount of harm and is suppressing the virus and doing its job. But what is interesting is that some of these less potent, I would say, markers of exhaustion, such as TIM3, etc., these may be less potent in terms of the toxicities that we will induce when we use these drugs. And while I talk about exhaustion always and talk about PD-1, this is really the tip of the iceberg. If we're able to identify some of these exhaustion markers which we can block and restore function without the negative effects, this may well be the avenue that we will explore. But the data is there around PD-1. It's hugely impressive in the cancer field. Is it realistically going to be transferable to chronic hepatitis B? We don't know that yet, but by studying that we can see that, I would say, triangle of agents which comes underneath it with less toxicity that we may be able to use.
Great.
So I would like to know your opinion about treatment with interferon. In Poland we have a national program for treatment, and we begin this treatment from interferon B. But unfortunately the results are not so good as we know. My opinion is that most of our patients are antigen E negative. These better results came from this earlier infected persons. It's true or not?
No, it's absolutely true. And what you find in your clinical practice is no different to what we find in our practice and everybody that uses pegylated interferon globally. I think what I would say is that the selection of patients for interferon may be something that we have failed a little bit on over the years that we've used it. And there are various kind of treatment algorithms and patient selection criteria whereby pegylated interferon may offer an advantage over other agents if we get that selection right. But I think everybody who treats patients with chronic hepatitis B will say the same thing, that pegylated interferon on its own as a standalone treatment is really, not the treatment that we want to use owing to its systemic side effects and its poor treatment outcome. Whether pegylated interferon will have a role in some of these sequential therapy strategies remains to be seen, and I would say the data that we've seen so far would suggest that there is a role for pegylated interferon at this juncture in some of these sequential therapy strategies.
Pavel, microphone number 2.
Kagan from Germany, thanks a lot for a great presentation. I have just a small question to last FDA saved the announcement for a few days because I had already some questions from my patients who read the internet and say the problem for somebody now, the AIDS treatment, and should we really need to evaluate our strategy for hepatitis B regulation during hepatitis C treatment?
It's a very good point, and this is something that we do need to observe. And it's, I suppose, a part of the diagnosis of these patients with hepatitis C that we're fully aware of co-infection or previous exposure to virus, because there's definitely a growing data there that we need to focus on to monitor this as we go forward. So like you, in our clinical practice, we are looking at these patients much closer to ensure that we are not getting rid of one virus and we're suddenly ending up having to look at and treat another virus later on. So our practice is probably no different to you based on the data that we're seeing.
Professor Yudadin?
Yeah. Thank you for the nice presentation. My question is about immunological approaches. You mentioned toll-like receptor agonists, you mentioned checkpoint inhibitors, you mentioned new vaccines, and overall all these approaches are very good in leading to immunological benefits. But in terms of what the clinician wants to see, let's say decrease in surface antigen levels or decrease in HBV DNA, it's always disappointing. For example, you mentioned the study by Gain, toll-like receptor agonist, no effect, but maybe the treatment duration was too short. Do you think that we will, at the end, finally find one approach which is clinically also beneficial, or will it be that pegylated interferon will be the best option in terms of immunological approaches?
Well, thank you very much for your question. I hope that we're not going to be here in 5 years saying, well, you know, after all that, pegylated interferon is the best option. I would anticipate that maybe we will make some progress, but I agree with you that in these early stage studies, some of the data is not impressive. But I think everybody would recognize that what we will do as we go forward in the treatment of hepatitis B, unlike hepatitis C, well, that these will be much more combination strategies. And I think it's the makeup of those combination strategies which may deliver that treatment advantage or improvement in treatment outcome that we're trying to achieve. Even we talk about surface antigen, you know, there's data emerging that the changes in surface antigen may not reflect what we're seeing in terms of cccDNA, so the pool in the liver. So again, we're back to, if you ask me, we're back to the drawing board to try and better define these disease states and what's actually happening. And you know, a lot of the work that focuses in this area is studying the periphery and peripheral blood lymphocytes and what's happening in the peripheral system. You know, we may need to look more at actually what's happening in the liver when we use some of these agents to kind of make progress and better progress in terms of offering treatment outcomes over the longer term.
All right, so I think we'll just have to invite you back in 5 years. All right, Pat, thank you very much.
Thank you very much.
Move on.
Thank you.